entire ADA in such a beautiful manner. And what impressed me the most is the part that he discussed. And I think that we have all been talking, not me, but my guru, Dr. Raheja, about epigenetics. We have been telling people that, look here, whatever your parents have given, you cannot change your parents. But what you can change is your lifestyle. I think epigenetics is a role of your lifestyle, your environmental factors, and we call them negative environmental factors. Today, genetically, if you see our studies, we are ethnically susceptible, but this so-called ethnic susceptibility to cardiovascular disease, diabetes, and cancer has increased in last 60 years. Before that, we had the same genes. If you talk about ethnic susceptibility, then 200 years back, we should have had the same number of diseases. We don't have. We have seen this disease in the last 50 years. So what has really changed in the last 50 years is the factors that Shashank discussed about epigenetics, out of which the most important factor is food. The food is a major epigenetic environmental influence on your already defective genes. They grab it, they start misbehaving with the slightest onslaught of food intake. So you have to study the food genomics, and what we call in our language is pinda. Now again, people say that you're going back to your own Hindu philosophy. That what is my pinda? I'm a Brahmin. I'm supposed to eat vegetarian, simple food. I'm supposed to get up at 4 o'clock, study. I'm supposed to stay away from vices. This is Brahminism. Brahma janati iti Brahman. Now you should see many of our Brahmins, they eat non-Brahmin stuff and they fall prey. Our genes, our genomes don't allow us to do things what we are not supposed to do. People don't realize that. And the worst thing is happening to our society. At a young age, the children are not eating home food. They are eating all fast food. They are eating all oily stuff. They are eating all processed, preserved food, pizza, chips, burgers. This is their diet. So obviously, epigenetics have taught us that although your gene is slightly defective, vulnerable, but your main problem is your behavior. Now, very nicely that lady has brought it about epigenetics. I think this is a time that we have to do introspection and find out from our own history and our own eating habits where we have gone wrong. The only way to prevent this disease in the next generation and the magnitude at which it produces complications can be only controlled if you put a lot of stress on epigenetics. I think that is a really eye-opener session, and Shashank brought it up very well. Now, obviously, he talked about this new generation once a week analog. Looks very promising. The reason why it's promising, it acts at 3 levels. It changes its amino acid sequences in such a way that it is released very slowly from the subcutaneous tissue. Then its albumin binding has improved so that it stays longer time in the body, and it is released at the receptor, and the receptor clearance is slowed down by an additional factor, which is basically makes it more albumin binding. Now, this is a promising molecule. Imagine you are taking an injection once a week. The challenges I feel in this, what he very nicely said about the cumulative effect, first injection, some amount of receptors are kept quiet. Second injection, some more amount of receptors are kept quiet. So it has a cumulative effect. Now, in an event of a cumulative effect, of course, these are all preclinical studies. We need to see that in humans. If you see a first injection, what is his day-to-day blood sugar changes. Second injection, what does it changes? Third injection, maybe the real effect of this drug will start showing after fourth or fifth injection. That's what I feel. Second question that is not answered by this very, dignified, very stylish technology. Does this person had to do without short-acting injection for a prandial control? Because this insulin eventually will control his blood sugar 24 hours, I understand. It will bring down HbA1c, yes. What happens to his postprandial blood sugar? Because see, in Indians, the major problem is a postprandial hyperglycemia. And the complication rates vis-a-vis coronary artery disease are related to postprandial blood sugar. So, does this molecule address that issue? That is one question I have to ask Shashank. Have they done multiple time related, meal related sugar studies? If so, if a basal insulin is very effective, then it cuts down the short-acting insulin. So that one question, I'm sure Shashank will elaborately explain. And a third thing, which I am very, very interested in knowing the basic sciences that he discussed, that fat, and that is also abdominal fat, and therefore portal circulation resulting into liver fat, is the main culprit of all the evils of diabetes. And that is one which is not really addressed by any drug, including SGLT2 inhibitor, including DPP4 inhibitor, and the only drug possibly mobilizes this bad fat from liver. So far we only have metformin. But is there any drug which can reduce this abdominal fat? Or is there any combination when we discuss the basic sciences so elaborately about abdominal and visceral fat and its role in pathogenesis of coronary vascular disease? So these are the three questions I am wondering whether Shashank can elaborate. Shashank.
So I think I'll take your last question first. And
Yeah.
I think the redistribution of fat is possible. And pioglitazone has done it the best, and followed by metformin and others. But they have not been sufficient enough. We have saroglitazar, but that class has not picked up. But redistribution of fat is important. I think it is the insulin resistance in the fat, the beta oxidation in the fat, which still remains an enigma, and that's something which we need to know. But a lot of agents cause weight loss. The GLP-1 receptor agents cause weight loss, and whether that weight loss is impacting the fat biology and its change, like for example the liraglutide or other GLP-1 receptor agents, because they have got positive CV outcomes. Liraglutide was the first GLP-1 agent to get that positive CV outcomes. So I think that's something which we need to recognize, that yes, directed adipocyte biology and its impact on insulin resistance and CV outcomes is an enigma, will remain an enigma. Currently the best drug is pioglitazone, but causes weight gain and has its myriad of problems related to fractures, macular edema, and so on and so forth. So that's the one challenge. Coming to your second question, is the once a week agent, it's only in phase 2, so it's not for prime time still. It's only in phase 2. This has got a unique pharmacokinetic mode of action without causing stacking, without causing hypoglycemia. But we don't know, whatever human volunteer studies they have done, with exercise, with food, how it will behave. What should be the subset of patients where they will not get side effects? Because that's a big concern. When you give once a week agent, the concern is that is it just going to be a small bolus basal dose, and is it going to impact overall biology? So the way the pharmacology has been tuned to appears that this is See, there are two types of basal insulin. The one which is secreted 24/7, and I think this is actually substituting the 24/7 basal insulin need which our body has, which may be around zero point 0.5 units per hour. That is how it is done. And the way the whole pharmacokinetic mechanism has been evolved appears that this is mimicking that. So maybe 12 or 24 units a day which we need. You just inject somebody maybe. Also, it's not going to be easy to titrate and dose. Remember, when you are going to give a once a week preparation, and will this last beyond 7 days? Will it just last a little less than 6 days? So all these pharmacokinetics and pharmacodynamics studies are ongoing now. I personally feel whatever data is in public domain, it appears that the coefficient of variation is less and it is sustained. There is no stacking and appears very promising. But proof of concept is phase 3 studies, which will now start after this phase 2 results, which we have seen at the ADA. So it appears very, very promising. What was the other question, sir? These were the two
I asked you about the question which is related to whether this drug needs to be accompanied with short-acting postprandial control.
Yes, it may need an oral pill or an insulin like a FASP, which might need to get that prandial control. So that of course will be needed, because as I said, basal insulin is 24/7, but every time you eat, you need to top it up with a bolus. So that's very true, and there won't be any need. But I think the overall need for bolus also will come down with the once a week insulin. So it appears very exciting.
I want to also,
and the ideal thing will be to have this once a week agent and then have maybe an oral insulin tablet, which can really make a difference in the lives of people with diabetes, particularly type 2 diabetes.
now the other thing, very interesting topic that you discuss about HbA1c. Now the hype of HbA1c has reached the common man at a grassroots level. Everybody talks about HbA1c. It's a good test, I agree with you. But how much to rely on HbA1c on diagnosis? Whether you can use it as a substitute to fasting and postprandial blood glucose, because I'll tell you, this is a question of a pre-employment patients who coming fasting and post-lunch sugar. For 3 days they starve, and they do fasting and feast, and they are declared non-diabetic. But you do their HbA1c is 8. So whether HbA1c has to be insisted at the time of pre-employment or pre-operative? This is my question, practical difficulty.
So it's a very common question, and you are absolutely right. Currently, we should not use A1C as a sole determinant for this. We should use it predominantly when we need to recognize that it has to be used for fundamentally complementary tests with fasting and prandial glucose or an OGTT. It cannot substitute an OGTT. And at least in the Indian population, where we have a lot of sickle cell, thalassemia, thalassemic traits, we have a Punjabi Kutchi population, Gujarati population, which has a high incidence of some of these traits. We need to be a little mindful and careful blindly using it. Also remember, a lot of India is anemic, and in anemia, the A1C values are not necessarily accurate. So we have a lot of HB variants in our population. So if you are doing it by the standard HPLC method, it's very inaccurate. You need to do an immunoturbidimetry method. So I think for diagnostic purposes, you need to be very mindful and careful, and I would not recommend it as the sole tool. It has to be used as a complementary tool. And even on follow-up, it's again not the sole tool. And we need to look at the physiological and pathological variabilities and the impact of A1C. Because when we see an abnormal A1C but fasting BP is okay, which we see very often, then we need to first see, is there a CKD, is there hemolysis, are they belonging to some other subsets and all that.
Another very interesting paper that you analyze, and it has got me interested because I deal with about 30% of my practice in this group, is a early nephropathy. Now, type 2 diabetic patients, the number of cases of nephropathy that we are seeing in last 8 or 9 years at an early stage of diabetes, well-controlled diabetic by targets of HbA1c. However, the hypertension is taken little lightly. And I always tell my students that look here, between HbA1c of 8 and a systolic pressure of 145, run after systolic pressure of 145, isolated systolic pressure is very commonly seen in our practice. Now, to prevent this nephropathy patients, the paper that you showed that it can definitely improve the EGFR, and the drugs which are now promoted, various studies like EMPA as well as canagliflozin, they improve the EGFR. What is your take on how do you prevent early nephropathy in type 2 diabetes?
So I think I'm very clear about early renal loss. To prevent early renal loss, you need tight blood pressure control, systolic, diastolic, and intraglomerular. I think it is a glomerular hypertension which causes the albuminuria leak. So you need to have a good ACE and ARB on board. Second is tighter the glycemic control, lesser is the early renal loss. So I think it's probably linked to the degree of glycemic control and to the use of a efficient blood pressure lowering agent. These two are the single two most important factors. The third is impactful is the lifestyle, whether it's diet, exercise, the protein load on the kidney. To save early kidney loss, you need good glycemic control, good blood pressure control, and clearly a lifestyle modification. If we do this early and appropriately, we have won the race on the nephrological loss. Also, there is probably a genetic predilection. Some people have the early renal loss faster, some people have it slower. Which one is faster, which one is slower is not easy to predict. And that is where probably the personalized medicine will come in. That is where a predictive algorithm, if we have, it might be useful. And currently I don't have that yardstick. I have to use that as a this thing. Other thing is the retina renal connect. So if there is in the retina a severe retinopathy, I know for sure that this nephron loss is going to be faster and quicker, and I need to use agents to salvage the kidney. So that's something where you can correlate better. But these are all ongoing studies. We need to do prospective interventions using various clinical tools to see whether we can arrest that early renal loss.
Unfortunately, what has happened today, at the age of 45, you see a lot of cardio renal metabolic syndromes. Means his metabolism is bad, his renal functions are borderline, and he has early normal ejection fraction cardiac failure, preserved ejection fraction cardiac failure. Now, these are the people who have to be treated aggressively. If you want to prevent this, I think what you talked about, the legacy effect and the metabolic memory, this has to come. So early hitting hard of type 2 diabetes is the guru mantra. Unfortunately, it is not taken seriously in the society. People take it casually in the first few years of diabetes. That attitude has to change by repeated counseling and repeated brainwashing. What are you saying of that?
I completely agree with you, sir. One more information I wanted to give you is on this IDEC program, which is the once a week insulin. They have a program called Onward program, which is a phase 3 trial of the program that should have started by now, but because of the lockdown and COVID, it is delayed. By end of the year, the Onward phase 3 program will start, and India is going to be a part of this Onward program. So we will get the first cut of how the molecule works in India.
That's very good. I think can we ask Bansi to get some questions from the audience if they are interested?
Yeah,
I will pick up some questions, and Dr. Bhoraskar, then you can start your
Yeah.
talk. I will be leaving in some time. That what is the degradation and excretion of iodec, and what is the effect of iodec in acute hypoglycemia? In acute hypoglycemia, we need to look at it. It's going to be a long time. And then the other question is Limoject versus Fiasp. There is no real major comparison study which was used in the ADA. And degradation and excretion of iodec is standard pharmacokinetics. I can send you the slides. Any other slides we have or questions we have?
sir, one question which I got is we talk about insulin resistance 5 sites. The question is regarding insulin resistance at the level of brain or central nervous system and its effect on metabolism.
So yes, brain is also, see, virtually every cell of our body is having a site of that. And they say insulin resistance of the brain is actually Alzheimer's disease. It's the type 3 diabetes. And if you give inhaled insulin, it will actually clear up your memory. So this is an investigational agent. So we don't know whether there is insulin resistance in the brain, and whether inhaling insulin will actually clear up the brain plaques. So currently what is known about insulin resistance of the brain is it's linked to Alzheimer's disease.
Anything regarding this insulin resistance at the level of brain has its effects on person's eating behavior or some anything
No, no.
related
It
to.
is it is linked. Insulin resistance of the brain is linked to
Okay.
memory, Alzheimer's disease, and there is a hypothesis that it could improve memory if you give inhaled insulin. But these are all hypothetical thoughts. So I am requesting now Dr. Bhoraskar to give you your clinical pearls of wisdom of as a clinician, how you should practice diabetes in 2020 in this post-COVID era. And I am excusing myself from this. But Dr. Bhoraskar, I want to tell lot of people have asked a question. People are still scared to use insulin. People are still scared to use in a long time. How are you managing your diabetic patients, type 1, type 2 both, sir?
Yeah, thanks,
There are-
Shashank. I think we will excuse you because you are a person married to many wives. So I'm sure you are in a great deal of hurry. So am I audible or am I visible? What is it?
You are visible, you are audible very nicely.
Right. Now, he has asked me to sum it up in such a way that how I have been practicing for last 40 years. Now, I tell you one thing, for what you talked about the insulin resistance in the brain, unfortunately in our country, and that is there in many countries, it's not only our country, there is a resistance in the brain to sensible suggestion. By and large, any sensible suggestion, any discipline that is going to be helpful to you, we Indians, we take it so casually and we do not understand the significance of social distancing. We don't know why we should not crowd in the markets and bazaar. One day they open the lockdown, people rush to the market as if there is no tomorrow. Now, this is a resistance of the brain to sensible suggestions which are in their interest. Now, the same thing, if you extrapolate in a larger scale, when a person comes to your clinic, either he is totally frightened by looking at the sugar level, he is frightened because one of his family member has undergone an amputation, or one of his very dear relative has undergone a bypass at the age of 35. He is motivated. He is shit scared. He will listen to you for 10 days, 15 days, 1 month, 1 year. 1 year later, he comes back with 5 kilos of weight gain, HbA1c by another 0.5% high, albuminuria, and they say, what happened? I say, we came to you, we followed the regime for 3 months, and then one party, this, that. So this is a resistance to sensible, logical, scientific teaching. How do you change that? You can change by continuing education in a very authentic manner. And I must say that we have to regularize our praise. All information which comes in the lay section of press as well as media has to be regulated by a scientific body. That does not happen. Many times some material comes in the newspaper which is not studied by a medical body, and diagonally opposite viewpoints are expressed. Somebody gets up in the morning, he says, well, this particular herb cures diabetes, my diabetes is cured. Now this should be regulated, and people should be taught basics of diabetes from school time. I feel the syllabus of nutrition and its ill effect must be introduced in the school textbook and should be given marks, because here I've seen if anything is given marks, people read it seriously. If it is not considered as your talent in academics, people take it lightly. Physical training, yoga, and this must be made compulsory with additional marks. That should be the government's policy to introduce healthy living from early childhood. This we have been telling continuously. We have taken up some schools, we have taken projects where we have educated school children, and we have seen the school children who are educated vis-a-vis diabetes, heart disease, and nutrition. They go home and they prevent their father or mother eating bhajiyas, vadas. They say, Dad, this is a bad food. This is not all-time food. This is a sometime food. All-time food should be bhaji, bhakri, chutney, koshimber, fruits. This is imbibed in the small brains. The school children are the messengers of all our information. That has to be done very seriously, and that is what I am trying to do as a Diabetic Association India Secretary. We have taken up some schools for education, and in fact, I have a paper that well-educated school children actually bring down the HbA1c in that particular community. I presented that paper in IDF. So this is what I tried to say, the basics. And I was very impressed by Shashank's discussion on epigenetics. I've been telling people that genetically we call ethnic susceptibility. We call ethnically we are people with famine, and there is a feasting now. We are genetically used to famine. Who the hell said India was a land where they say Sone Sadhur? India was a land of plenty. That's why all these people came and attacked Indians, right from Christopher Columbus to East India Company. Why the hell those bhikaris came here? Because we were rich people. We were not starving. We started starving from Churchill's time. Churchill was responsible for this famine. We are not famine-starved people. Now this theory that we were famine and now there is a feasting, and that's why we have developed type 2 diabetes. That is wrong. Our diet, our nutrition with our great forefathers were eating was absolutely perfect diet vis-a-vis dietary fats and Rutucharya. We used to observe the diet according to the change of season. And it was such a wise thing to do, which we gave up because of the media and this fast food industry. This is my one-man crusade against this. We have to educate people against their own virtues of their customs, and their festivity can be reduced in terms of eating habits. There should be more exercise-oriented activities. There should be more physical fitness. There should be more peace of mind. There should be tranquility. Now it's very impossible. This today days of COVID and all, and the lockdown and general slowdown of is not going to be peace. Peace is not going to be possible unless you change your mind and look at the adversities as an asset. Consider COVID as an opportunity to improve your personal discipline. Government is telling you to wash hands and keep clean and also observe certain social distancing. You have to follow it. So follow discipline in life, in nutrition, in your accounting, in your bringing up the children, and that is the mantra of Sukhi Samsar. People don't follow it seriously. People want a pill. Now, I don't know how many people will follow this advice. Now, this once a week insulin, people will read about it, and every second person coming to my clinic will ask, "Wo kabhi aayega injection?" Because that they get a feeling that they take once a week injection and they are free to go to any restaurant and eat what they like to do and do what they like to do. Diabetes treatment with pills does not give you license to eat anything. Eat anything that you want at any time. Pill does the job of controlling sugar 5 to 10%. Pharma company will not like my saying this, but the 95% job is in your own hands, your own lifestyle, in your own behavior, and your own traditional methods of controlling evils. First is evil mind. Try to soothe that. Try to stabilize that. Do not have too much of ambitious, which is out of control. Have ambition. I'm not saying you should not. You should work hard. Academics, business, but do not have competitive spirit, because this fellow goes to five-star hotel and eats here. His family goes and eat ragda patties, pani puri. I will also go. Don't follow wrong things. Eat at home. Eat virtuous food. Your mind will also. Man is what he eats. If you eat sattvic ahar, your mind becomes sattvic. Wrong thoughts don't come. Wrong thoughts come in your brain when you eat wrong food. And that starts from the childhood. Your children will also become sattvic if you give them virtues of milk, fruits, nuts, exercise, and they don't fall into traps of this media. The media is playing havoc, and all these big time celebrities advertise food products. You should ban their pictures. Luckily, the pictures are not on. But I'm totally against children going into energy dense drinks, milkshakes, which are advertised, which are packeted foods, which are advertised on and a young mind is a very impressionable mind. That has to change. So this is my take home message for all of you. It may be boring, it may be less scientific, and you may feel I'm not showing you slides, but this is my 40 years of experience, and I've been teaching all this to my patients. About 20% patients fall off. In last 40 years, I still retain 80% of my patients. 20% people go here and there. I don't mind. If I talk about insulin, they will leave me and then come back after 10 years. I say, what you told us 10 years back, we should have listened. But 80% people stick to me, and 80% people are really benefited, and they are enjoying these benefits on a long term. My average patient that I am seeing today, he is 75 to 80-year-old. So last 40 years they are taking treatment from me, and they are alive on the same planet and they still patronize me. So they don't leave me easily. Initially they feel they both khadus doctor hai, but eventually they say I am telling everything in their interest. I use minimum drugs. I use minimum dosage of insulin. I do monitoring regularly where it's required, but not maniac monitoring. Every day, 5 times testing. I don't do that. So balance between the convenience, compliance, and sound theory based on present research. This is my Guru Mantra. Thank you very much, Bansi, for giving an opportunity to express my views. And I have to comment that Shashank has done a wonderful job in spite of so much of responsibility the young boy has now on his head. And I'm also extremely proud of Bansi for putting up a grand show with all faculty very committed, dedicated. They're all authorities in their respective fields, and the program looks very impressive. It will definitely give the delegates its worth and worth spending Saturday, Sunday on such a program. Thank you very much.
Thank you, sir. One thing more, would like to have your advice in how you motivate your patients for physical activity, because this is the thing where we all are failing. I mean, I am failing. I'm not saying we all are, but people are not getting motivated, or they are not doing, or they are not turning up for the physical activity. Or even if we have some counseling session, they would say, Dr. Zab, I will not be able to do this. So what's your thought process, how you advise and how you go for that?
I'm very glad you asked me this question, because you appear from your face a very simple and a very innocent fellow. So you have no tangent motivation in asking me this question, that how do you motivate your patients when you yourself are like this? So I don't take that way, but I agree.
Yes, sir.
motivating patient to exercise needs a person who himself should look like Salman Khan.
Oh.
You understand? I mean, that is what the patients are motivated. Doctor, aapke jaisa. But you try to understand that when I talk to them, I say, look here. Then I show them some of my photos 20 years, 30 years back when I was an athlete. I was a swimmer. And I said, this happened to me because of my multiple accidents, and that doesn't justify, I said. But I observed certain amount of fitness, and I told them that in spite of my both the knees operated and my disability, the amount of exercise that I do, and I showed them my timetable. So they were quite impressed. I say, yes, and in spite of that, you do this much? I say, yes, I do. Without that, I don't eat. So remember one thing, you have no right to eat unless you do exercise. That is first principle. You will eat only if you have done at least 20 minutes of vigorous exercise, which should allow your cardiac fitness to perform, or a simple free hand exercise, yoga, pranayam, and free hand stretch exercises, and a brisk walking if possible. You have to do this. Then I say, ki, look, what is the insulin that you are taking? I say, I'm taking 45 units. I said, don't you think you should take about 20 units? I said, how do I do it? I said, very simple. If you increase your physical activity, your insulin requirement will go down. The moment your insulin requirement goes down, you will lose weight. He said, what are you saying? I say, you're measuring abdominal girth. In fact, I tell all my patients to keep a measuring tape on a dining table. I say, let it be a habit to measure your abdominal girth every day before you eat. And if the abdominal girth comes by even by 1 centimeter, you have achieved 10% of the target. He said, what are you saying? I said, that is only possible when you do good exercise. Many people are motivated. Many people calculate the cost of insulin and benefits based on that. Many people calculate the cost of hospitalization and possible angiography, and they say, no, I'll better do exercise. Many people see the benefits of people who are doing exercise regularly and their well-being. I also tell people that apart from reducing weight, apart from increasing cardiovascular fitness, exercise gives you a high. It creates beta endorphins in the body, which is endogenous morphine, which gives you feeling of high. And you get a feeling that koi bhi आपत्ति आएगा, मैं निपटा दूंगा. This positive attitude you develop, people who exercise like Bansi, always smiling, always cheerful, ready to face any emergency. This attitude comes by regular exercise and yoga and pranayama. People who do exercise regularly, they are different people. They are cheerful. They don't grumble. Otherwise, diabetes is disease is full of complaints. इधर दुखता है, पैर में जलन है, ये है, वो है. All these negative symptoms disappear the moment you work out. And you think positively, you get good ideas, you're cheerful, you're liked by people, and you can achieve a lot of things. I'm not trying to chadao by Bansi, but look at his achievements. He has achieved so many things at such a young age because of the positive vibes that he creates. When people like Bansi and all this come in your life, you get positive ideas. You don't get depressed. Same thing, diabetics who take exercise regularly, they are better persons to deal with. Their bosses are happy, their subordinates are happy, their colleagues are very happy. When they are popular, and there is a benefit of exercise. I don't think I can say anything more than that. And I am not an authority to prescribe a particular exercise, because people will say कि डॉक्टर साहब आप तो ऐसे हैं तो कैसे आप recommend कर सकते हैं. But I think I can fight my adversities if I do exercise regularly. Anything else?
No, thank you, sir. And it's really, you truly said, because when I joined with Dr. Bansi sir, after my MD, I was 85 kg, and right now I am 68 kg. So that's the motivation regarding good nutrition and how to live the life and how to go ahead. I went because when I was sitting in a chair as a doctor and I told my patient, your belly is coming out, I was looking at, oh, my belly is also coming out. So first of all, I need to flatten that. So, and then that confidence came to say to the patient, and now to be with the patient to motivate them continuously. And we are also getting motivated from Bansi sir also for that. So regularly, such education campaign and everything, we run out for that.
See, my friend, but when you say, when I joined Bansi, I was 85 kilos and now I'm 65 kilos.
68.
Somebody may say that whether Bansi is not paying you adequately or
No,
is starving.
that was comment came from my professor, my MD professor. When we were in a meeting, he told Bansi, you are doing some mischief to my student or what? Then he said, oh,
No,
he's
but it's
becoming more
commendable.
healthy.
If you lost 20 kilos of weight, it's really commendable. You stay like that. Most important, loss of weight is important, but to maintain that
Yes, sir. Yes.
is important. And with Bansi around, there's so much of activity, you will always remain like this, I'm sure.
Yes. Of course. Always we are feeling on high only,
That's right. That's
and
right.
feel motivation.
Anything else?
Any other comments, Rutul, from your side? Do we have any questions? You need to unmute.
In chat box we have many questions. I guess we should address them before I have any question. So
Yeah, what are the checkbooks? Show me them.
yes, the question and answer from Dr. Surinder Gupta, Dr. Sanjay Kumar Rathi. So Dharmendra bhai, you can ask that question.
From Dr. Surinder Gupta, he is saying promoting habits of physical exercise. Every doctor should have his or her exercise picture to influence confidence. Dr. Surinder Gupta, Diabetes Free World, Ludhiana. So he has just one suggestion that we should keep our pictures of doing exercise to influence the patient.
Okay.
It's a good idea. It's a good idea.
Yeah.
Only thing,
there is a question
people should
from
not
Sanjay Kumar Rathi.
should not miss.
Sir, you are mute. Bhoraskar sir, you are mute.
Okay, can you hear me?
Yeah.
Yes.
Yes. There is one question from Sanjay Kumar Rathi.
Yeah. Mr. Dr. Rathi, what is his question? Sorry.
What are the chances of all-cause death in diabetic if he is only on insulin from very beginning and does not want to take OHA?
I understand. If a person is only on insulin and he has addressed the issue of insulin resistance. Now see, one problem with insulin is that you gain 4 to 5 kilos of weight. And that, if it is on the abdomen, if you're taking insulin on abdomen, the more chances that this abdominal obesity increases. If he allows that, then it's risky. But if he doesn't allow taking insulin and reducing chances of abdominal obesity without taking any medication, he has an excellent chance to live long enough without complication. There's no doubt about it. If HbA1c is 7, but he manages to reduce his weight. Now that's a tall order, because as soon as you put on insulin, you gain weight. But actually that weight gain is a lost weight which you regain. But after that, he should not put weight, and particularly on abdomen, the visceral fat should not increase. If that can be managed, then he has got no chances of developing complications. This is what I got quite a few patients who are on insulin for 25 years and they are ideal body weight. They're actually 4 or 5 kilos less. They are mainly muscles and very little fat. They do very well. One of my patients is 84 and he is a marathon runner. So, but again, people on insulin, must also take exercise. There is no substitute to exercise. Insulin is not a substitute to exercise. Get it very clear.
Many times when we talk about weight loss and a person is a patient who is new to coming to us, he may have weight loss due to his or her his glucotoxicity, and he will just argue, doctor sahab, just I lost the weight and still I am not able to be fine. And so what's your opinion in just saying the patient regarding it's not the weight we want fat loss, or how we can propagate this terminology, or we can put this in patient mind that it's not the overall weight, that is fat loss which is important, or what is your thought on that?
What I do a complete measurement of a patient when he comes first. Arm fold thickness, arm size, calf size, mid thigh size, abdominal girth, and I see his muscles, I see his fat muscle distribution. Write it down. 3 months later, we check all the parameters. If the skin fold thickness on the tricep area has reduced and his muscles have become strong, I'm not saying larger, but strong, and you can feel them, and the abdominal fat from the side, not in the belly side, but the side, has come down. The skin fold thickness on the lateral aspect of abdomen has shrunk. Then he is on a right track. And then look at the weighing scale. By then he has lost 4 to 5 kilos of weight, but it is very clear he's lost the weight from the volume contraction. If he's on SGLT2 inhibitors, that's one advantage. He has lost in the urine, he's lost his extracellular fluid, and the fats have come down. But his weight has lost, but his abdominal girth has increased. It has defeated the very purpose we are treating the diabetes. And such people will need localized exercise. What is a localized exercise? You train them to do abdominal exercises. You ask them certain asanas of extension of legs without rising the BP. Monitor the BP. Ask him to do what is known as Kapalbhati. Again, Kapalbhati increases systolic blood pressure. So after each act of Kapalbhati, check the systolic pressure. If the systolic pressure goes more than 145, he cannot do Kapalbhati. Then abdominal bends, lateral bend, side bends, Tadasana, Ardha Machindrasana. These are the things which will mobilize the fat. And of course, cut down on fat. Cut down on dietary omega-6 fatty acid. Bring down the cooking medium of 2 teaspoonfuls of rice bran oil in a day and 2 teaspoonfuls of ghee or coconut. That's all he's allowed to eat in a day. Cut down on the carbohydrates in the lunchtime and dinner time. Have little carbohydrates at the breakfast. Increase a bit of proteins like sprouts or white of egg, and cut down the afternoon lunch. Cut down the dinner carbohydrates. This is what I do, and many people follow this advice. They feel a lot better. And once the inches come down, they can go to a nice wardrobe. The shirts at the time of marriage, what they have purchased, I'm sure the girl side had presented them. They have kept it in the cupboard. Now it's fitting them. He says, Doc, this shirt my wife got me at the time of my wedding 15 years back. I can get into that. I say, it is not only that, what you are doing in 15 years back in the bed, the same thing you can do that also. That's an advantage of fitness. So many people are motivated when you encourage them like this.
Yeah. Thank you, sir. Thanks for the enlightening session and really a wonderful and practical advice to go with the patient and how we can motivate, we can counsel for the true type 2 diabetes management. Thanks a lot.
Thank you very much.
Yes.
Now, should I leave or what is it? Is it done?
Yes. So we are concluding the session now for today. and we will start here the next session at 2:30 p.m. Till then,
Thank you very much.
Lunch break. Thank you, sir.
Thank you, Bansi bhai, and thank you all of you.
Thank you, Rutul, and thanks, Akash.
Thank you.